47-year-old male. 10 years previously, he had a right acetabular posterior wall fracture. This was treated with some screw fixation, and he had a sciatic nerve palsy. He does not remember whether the palsy was before surgery or after surgery. So now it is painful, severely restricted. There is 4 centimeter shortening.
Right. Vidya, just hold on.
Yeah, okay.
Bosley, sir. Dr. Bosley.
Yeah.
So what were your opinions, sir?
Have you done EMG nerve conduction and CT scan?
No, it's a 10-year-old injury, sciatic nerve. He has got a foot drop. Completely.
So there's a
Zero power. Ankle has become stiff in equinus.
Sensory?
Right? All gone, sir.
Complete zero. So no pain.
He has pain in the hip.
Severe pain, sir.
Only
Pain in the
Severe
hip.
pain, restricted movement, sir. What would your plan of action be in this, sir?
Have you done
CT?
CT scan?
Yeah. So you can see the long screw on that second film is going precariously near the sciatic nerve. Maybe that was the reason for the injury. We don't know.
So any other, so what would your choice of implant, what choice of approach implant and be in this? Sir?
Yeah, so basically you can do a dual mobility is a ideal answer.
Okay.
Karkhane, sir, any other views?
Got a lot of heterotopic
actually-
ossification.
Yeah. So I am not an arthroplasty surgeon, but I can just see that in the AP, X-ray, AP pelvis, both the obturator foramen are looking normal. So therefore, what they had said in the previous presentation, Dr. Nemade and Dr. Mohan Desai, that there is rotation of the inferior fragment, that does not seem to be. So therefore, what Dr. Bhosle says is correct, that we should do a arthroplasty for this patient. Because the acetabulum here, that is the weight bearing area, will be normal. There is no rotation of the inferior fragment.
Okay, Vidya.
Yeah.
What did you do?
So now this is the X-ray. Let's define the problem. That's the position of the native socket, and that is the extent of the acetabular defect. So the vertical extent of the defect is approximately 2 centimeters, the proximal migration. As you can see on the X-ray, there is no ischial lysis. There is no lysis in the teardrop area. So this is a Paprosky type 2B defect. And so, yeah, can I ask the panelists, what is the, yes, Dr. Sangeet.
So as long as the bone stock is there, you can use a large cup and
Jumbo cup.
obtain a stability intraoperative.
Yeah.
Once you cut the neck, you will get mobility. Whatever bone keeps in the way, HO, you have to remove it. Yeah. And there's a good bone stock, 10-year-old, so everything
He's
is...
young patient, 47.
Yeah.
Yes. No, I don't have it here now.
Superior portion of the lip is not there.
Okay.
Okay. And then getting down in the true center is also going to be difficult unless you are going to accept the high center.
Yeah. Dr.
So
Sangeet,
I think you will require an augment.
Yeah.
I would do sort of a flip osteotomy and use something like a distal loading stem, because I would like to sink it inside. The usual standard tapered stem, you may not be able to sink inside, and the reduction of the hip may be difficult.
So is the hip ankylosed?
No, there is some movement, some jog of movement, but very painful.
So why don't we do osteotomy, retain whatever the bone is, and ream at the native acetabulum? So why do you want to take out all those where you feel is a defect? Because we don't see the cartilage, we don't see the joint at all. It is already fused.
No.
We retain that as a bone stock, and in the native acetabulum, rim
Okay,
and
yeah, okay.
socket.
So
Put a
with that,
socket.
you are looking at whether you can bring the cup down to the normal anatomical level.
Yeah, I'm contemplating what are the options.
Okay, but
Yeah.
the
So-
other, with what the history you gave, that this patient already has a fixed equinus at the
Ankle.
Getting it down and lengthening that leg is not going to make him very happy.
Yeah.
Okay, you can't, either you have to do that or you have to correct his ankle in the next stage.
Yeah. So,
So I think what Sangeet said, if here you can get a hemispherical, leaving the HO in place wherever you get, and if you can get a cup,
Yeah.
which may be slightly higher hip center than normal.
So our options are on the socket side. The ideal option would be to place the cup in the normal center of rotation, and whatever defect we have superiorly, we put in a augment. Now this is technically challenging. It requires a lot of dissection as well as it's costly. Another not so ideal option would be to use a bone graft to just ram in the bone graft in place of the in the defect, but then the bone graft will have to be supported with a cage, and the cage will not take a uncemented cup. We'll have to put in a cemented cup. This is not a biological solution. Its patient is young and not a very ideal option, though it will give a ideal correct center of rotation. So my preference would be option 3, actually, what Dr. Shahane said. Accept a high hip center, make use of the good bone which we have superiorly. In this case, the high hip center goes about 2 centimeter proximally, which is not terribly high. And given the fact that the patient has got a foot drop, that added clearance of 1-2 centimeter may be beneficial for him. So that's the idea. On the stem side, femur looks fairly okay. So the first option is to put an uncemented tapered stem. That will work. We can also put in a cemented stem. That also will work, will give us more option with respect to craniocaudal placement of the stem as well as the version adjustment. But then again, my choice here is a modular stem. I am not sure what version I would get in the socket side. So I want some more freedom from the femoral side. That's why a SROM type stem would be my choice here. Any comment? PB, sir?
Not absolutely required. So with cemented also you can give a
Yes.
whatever version you want. It's about 10-15 degree change.
Yeah.
So that is possible with cemented also. And it's not absolutely required that you have to use SROM.
Sir, Vidya, you said cost constraints, so forget the SROM, please.
For the first option.
You just said cost constraints. That's why I'm thinking only from that type.
Okay, okay.
I think Vidyanand, we
Viva is
are
okay.
only seeing the two-dimensional. We have to see whether that posterior aspect of the lip is there or not. You have to show us.
Yeah,
We
okay. I'll
have
show it on
seen-
the post-op X-ray. We have.
Vidya, now we'll have to
Yeah.
ask you to move
So,
on, please.
yeah. So
thank
that's
you.
all the mug that was removed from the fibrous tissue. The implants were loose. The screws came out very easily, and I could get a good fit with the Pinnacle cup. Pinnacle, that is the trial cup in place. Good superior posterior coverage, and I put in a +4 10-degree lip liner. SROM stem. Cost was not a problem in this patient actually. So ceramic head.
Vidya,
Okay, so
don't
that's-
use,
that's-
use your
that's
words
what
with
you have done.
care. Remember what you say.
Yeah. Okay, so finally, the upshot is that he has got a 1 centimeter shortening now, which is serendipitous. And we are given post-op indomethacin and radiation. Any comment on the coverage of the cup, Sunil?
The cup coverage looks good. So here, once you had your cup in,
Yeah.
what was the reason why you still went ahead with the SROM? Could you not get in a normal stem in there?
No, I had kept SROM and cemented options. So
He wanted to increase his experience with the SROM.
maybe that's true.
Yeah, that's true. Okay. Thank you, Vidya. Thank you
Yeah,
very
but
much.
I'll show a follow-up.
You
This
should
is a
have
4-year
removed the
follow-up.
bone. You should have removed the excess bone.
I didn't want to dissect too much in the myositis mass.
Use the burr and that's the
Okay,
ideal
okay,
thing.
yeah. So this is the 4-year follow-up. The cup seems to be incorporated well. Function is fairly good at 4 years. And he followed up with me for 6-7 years also, and then he was lost to follow-up. Thank you. Literature supports a high hip center.
Thank you.
Probably the